Welcome to video 5 of the Safe Recovery Training Program. In this video, we discuss framework number 2. Why don't patients engage in falls prevention activities? I'm Terry Haines. The objective of this video is to understand what patients think will prevent falls, and also to understand why patients may not be motivated to participate in falls prevention activities. When we've asked patients what they can do to reduce their risk of falling over in hospital, we've had a range of different responses, though some of them have been more common than others. If you want to find details of these responses, you can look up this particular paper published in Health Education Research, written by my PhD student Angel Lee, or you can look up this particular paper written by Anne-Marie Hill, published in The Gerontologist. The focus of this second study was on the post-discharge period, but the responses of participants are still very illuminating for getting inside the head of what patients actually think. But to summarize this research in a very brief way, the common responses we get are to be careful, to not rush or to take my time when performing activities, to not do silly things, or to avoid a particular environmental hazard. Each of these responses are quite non-specific, and they're things that people are probably trying to do anyway. Helping patients to identify specific, relevant strategies is an aim of the Safe Recovery Program. Now, once a specific, relevant strategy has been identified, how do we help a patient to engage with it? Well, to do this, we need to understand why they might not want to engage with it. There's many theories available to help explain why people engage in certain health behaviours. There's a very nice review paper by Gillen, published in 2003, to explain how some of these behaviour change theories might be applied to injury prevention. Another model worthy of mentioning is the COM-B model, very simple model, that's been developed and come to the fore since this review paper was published. So I'll have references to that particular model in a later video. The key contention, though, in understanding why people do some things and not others usually boils down to this very simple question: what's in it for me? Linda Evangelista, a former supermodel, captured this beautifully, I think, with the statement, "I won't get out of bed for less than $10,000. Framework number 2 is based very much on this proposition, that it's all about me. What's in it for me? We've used the scale approach again, similar to framework number 1, and on one side of the scale we have what the patient perceives the benefits are of undertaking a particular strategy or falls prevention behaviour. And on the other side of the scale we have what the patient perceives their costs are for undertaking that same behaviour. Now, if we look at the different factors that might impact upon perceived benefits and perceived costs, the first one that I'll focus on is that of threat appraisal. Threat appraisal is a combination of the perception that somebody is at risk of falling over and the perception they're at risk of hurting themselves if they were to fall. To me, there is a hierarchy of threat appraisal that you can explore with your patients. You can find out whether they think people fall over in hospital in general. Many patients are surprised when you tell them that falls are a problem in hospital, and previous to that had been thinking that hospitals were very safe places to be, not the place with the highest rate of falls that they'll probably ever encounter in their life. The next level of threat appraisal relates to whether people think that people like them might fall over while in hospital. Some people think that falls are restricted to older people, people who are frail, people who can't walk properly, and they don't classify themselves necessarily in that same way. But as we have seen, the risk factors for falls in hospitals are different to in other communities, and in rehabilitation wards we know that age is not a protective factor against falls, that young people tend to fall just as much as older people if they're on a rehabilitation ward. The highest and most important level, though, of threat appraisal is whether people think personally whether they will have a fall themselves, whether they're likely to have a fall while in hospital. Now, a similar hierarchy also exists, of course, for perceived risk of harm from falls as well. Now, when we've asked patients in our qualitative studies whether they think patients fall over in hospital, here are some of the characteristic responses we've received. It's hard to say. I haven't seen it. I wouldn't know. I haven't seen it. Well, there was a lady who fell in the bathroom. Very much these responses are based on their lived experience. A bit like doubting Thomas. If you haven't seen it for yourself, it doesn't exist. Do patients perceive a risk from falls? We conducted a study of 125 rehabilitation inpatients and found that 17% thought they would fall during hospitalization and 22% thought they would injure themselves if they were to fall. And if you want further details of this research, you can find it in the journal Open Longevity Science. When we look at trying to profile the people who think they're going to fall or hurt themselves as a result of a fall, we see again this theme of the lived experience dictating who perceives the world in different ways. So if we look at people who perceive that they're at risk of falling over, we find people with better cognitive function were less likely to think they were going to fall over, and people who had had a fall in hospital prior to the survey being conducted thought they were more likely to fall over again prior to leaving. Again, this is very much driven by their lived experience. For those predictors of people who think that they might hurt themselves if they were to fall, we find that people with an orthopedic diagnosis, including people who had had a fracture in the past, they thought they were more likely to hurt themselves again if they were to fall. People with better motor function and people who are better able to care for themselves also were less likely to think that they were going to fall over and hurt themselves if they were to fall over, I should say. So threat appraisal is a critical element in having people perceive that there will actually be a benefit to them from undertaking a falls prevention behavior. What's the point of trying to do something to prevent falls if you don't think you're going to have one, or if you think you're going to, even if you think you're going to have one, it's not going to do anything bad to you. The next issue to discuss is people and their desire to avoid falls or harms. Some people may accept that they're at risk of falling and at risk of hurting themselves if they were to fall. They just don't care. And quite often I found people with depression in hospital, which is a very common occurrence these days, that these patients may be able to express to me very clearly a rational amount of risk for falls and harm from falls, yet they don't value their safety. And I find this a perplexing thing to try and deal with. But certainly there are people out there who will recognize the risk of falls but have very little desire to avoid them. Another factor that influences whether patients perceive there will be a benefit of trying to undertake a particular falls prevention strategy or behavior is the perception that the strategy will actually work. If people think that, oh, there's no way that that could work, then they're not going to be very motivated to actually try that activity. Similarly, if they think that the activity that you're asking them to perform is far too hard, then they're going to have little perceived benefit of that particular activity for them personally. This might relate to activities such as waiting for help to arrive if they've asked for help to go to the toilet. Some people perceive that their ability to wait is very limited and they become very impatient, and they know that they're going to try to get to the toilet on their own despite the risks that they're facing. A final factor that influences the perceived benefits of undertaking a strategy might be perceived benefits unrelated to preventing falls. To me, the best example for this comes in the community setting for falls prevention, where you can encourage people to do an exercise program to prevent falls, but similarly you could encourage them to do the exercise program to improve their strength, balance, independence, mobility, and how good they feel about themselves within themselves. And that might be an even greater catch than anything to do with preventing falls themselves for that individual. When it comes to the costs, there may be perceived financial costs, there may be emotional costs, how people think about themselves. I recall when trying to offer a patient a pair of hip protectors one day, she said, "Oh no, I couldn't possibly wear them. They make my hips look wide." And she was deadly serious. Her self-esteem, her self-image would have been threatened by having to wear the hip protectors. So there may be costs that the patients perceive as a result of trying to undertake a strategy. Physical costs also commonly get raised by patients in terms of experiencing pain with trying to do physical activity. There may also be perceived costs to others. Now, this is an important thing that can come up. Some patients are reluctant to ask for assistance, say for example, to go be driven to an exercise program because they feel that their relative who is going to drive them is too busy and they don't want to be a burden to them. Similarly, in the hospital setting, patients often don't want to be a burden to the nursing staff who are caring for them and may avoid asking them for help because they perceive there is a cost to the staff caring for them. So this framework is then completed by considering all these different factors. When trying to understand why a patient is or is not undertaking a particular falls prevention strategy that's been discussed with them, then think about these factors and which of these things are impacting upon whether the person is performing that particular activity or not.